Welcome to Brain Ponderings, your window into the world of neuroscience research with conversations with experts in their particular subfield of neuroscience. And today it's my pleasure to welcome Corinde Wiers, sorry, or Wirtz, um, Wiers, I guess is the way to pronounce it. She's
Beers,
an
but nobody can pronounce it. Yes, sorry.
assistant professor of psychiatry at the University of Pennsylvania Perelman School of Medicine and appointment in the Center for Studies of Addiction there. Her training is in addiction research, and she moved to Penn maybe just a few years ago, I guess, and has her own research program going there now, focused on clinical work. So welcome, Corinne.
Thank you so much, Mark.
And can you talk a little about, so you're from Germany originally or Europe somewhere?
Definitely Europe. Yeah, no, I'm from the Netherlands
Oh,
originally.
Netherlands.
Yeah.
Okay. All right. And when did you get interested in the brain and how it works?
Ooh, good question. I think I was always interested in the brain in high school already, seeing also mental disorders around me in school, also in my family. So I went to study psychology at the University of Amsterdam, and then a new study started called psychobiology. And so I switched because I thought psychobiology was both in the psychology department, the biomedical science department, and in the medical school. So that was a perfect field for me, at least, to be trained in all these different areas. And then it took me quite some time to understand what level of the brain I wanted to research. Do I want to do animal models, genetics? But I was always, yeah, more interested in the clinical questions. So I ended up pursuing first a master's in England at the University of Sussex, where I
Wow.
really became interested in addictions, so much alcohol use in the UK. And then a PhD at the Berlin School of Mind and Brain in Berlin, Germany. So there, I work primarily on functional MRI in people with alcohol use disorder.
Okay, that's why I was thinking Germany, because that's where you did your PhD work.
Yeah, I may have picked up a German accent in my English too.
What was your PhD dissertation? What's kind of the problem you were trying to address and the take-home message of your results?
I was primarily interested in unconscious attentional and approach biases in
Hmm.
alcohol use disorder. So we found with just behavioral tests that people approached alcohol cues faster. And then I coupled it with the functional MRI and showed that more reward-related brain areas, such as the nucleus accumbens and medial prefrontal cortex, were implicated in that. And then we performed a behavioral training that taught people implicitly to disengage from these cues and found that that reduced this triggered brain reactivity. So I was really intrigued by, can behavioral interventions have an effect on the brain?
I had Roshan Cools on a previous one. I'm sure you know her, and
Yes.
we were focusing on cognitive control and ADHD, and but so you mentioned the nucleus accumbens, which is kind of key brain center where dopamine's released onto, and that's a lot of the focus for addiction. But there's also dopamine neurons that project to the prefrontal cortex and kind of they're very important in your like impulse control and be able to focus and stay on task or shut off impulses, I guess was one thing that prefrontal cortex does.
Yeah, Roshan is fantastic, and yeah, leads a lab on PET or positron emission tomography in Nijmegen in the Netherlands. So during my PhD, I was not involved in PET research, but then when I moved to the NIH to work for Nora Volkov as a postdoctoral fellow, that's where my PET training started. So also, yeah, measuring dopamine D2 receptors, which are very much downregulated in people with addiction, including alcohol use.
And so Nora's the director of NIMH. And so how was that working with her? I mean, she's got a lot of things going on. And so did she have a lot of staff under her that worked with you on a day-to-day basis? Or I'm just kind of get idea how much.
Yeah, so Nora, it has been fantastic to work in her lab. She's probably the smartest and most motivational person I've ever met. So we always had weekly meetings with her on a Friday. So yeah, she's the head of NIDA, the National Institute of Drug Abuse.
Oh yeah, yeah.
Because of that, she cannot have a lab at NIDA, but she had a lab at the
Oh, yeah.
Alcohol Institute. So we had a lab, or we were working in Bethesda, Maryland, in the main building, the
Yeah.
main research building. But she actually had a surprisingly small lab. We were with 3 postdocs and 3 staff scientists. It when I learned about her, well, she had just moved from Brookhaven National Lab, where they had a much larger lab, to the NIH.
But it makes sense. Then she can, each postdoc gets more attention that way, and it's easier, because she's so busy with other things all the time.
Yes. So
Yeah,
throughout the week, she was busy with NIDA and policy, speaking in front of the Senate, etc. And then on
yeah,
Friday, she was working in the lab.
yeah.
But she was on top of everything. So
All right. And so at NIDA, did you do PET imaging there?
yeah, we did PET imaging and also functional MRI, structural MRI imaging, and we were able to do clinical trials in people with alcohol use disorder, because the NIAAA has an inpatient unit right there on campus. So we did a lot of brain glucose metabolism with FDG, which is commonly used for
Yeah.
cancer research, Alzheimer's research. And for years, she had already found that people with alcohol use disorder have lower glucose metabolism. And when people drink alcohol acutely, also glucose metabolism goes down by roughly 20%. So initially that was interpreted as, oh, look, the brain doesn't function well on alcohol, and that leads to all these cognitive problems. But just before I joined her lab, she just published a paper that rather than the brain doesn't have any energy, there's a shift in metabolic energy with acute alcohol intoxication, namely glucose goes down because acetate, which is a metabolite of alcohol. So when you drink alcohol, the liver oxidizes alcohol into acetaldehyde and then into acetate, and acetate travels to the brain and can be used as an energy source. So when you drink alcohol, basically your brain functions on acetate.
Well, right. So with the PET imaging to look at glucose uptake into brain cells, it's well known during aging and with mild cognitive impairment, and then much more so in Alzheimer's disease, there's impaired glucose utilization. And Steve Quinane probably. I've
Yeah.
had him on previous podcasts, actually twice. And so he's used radio-labeled um, acetoacetate, right, which is one of the ketones produced during fasting, and simultaneously looked at cells' ability to take up either glucose or the ketone. And depending on what the blood level of glucose or ketones is, they switch. So if ketones go up in the blood, they switch to using uh, ketones, the brain cells, and presumably it's mainly neurons using it. Um, and do you have an interest I mean, that would be certainly good to do in the substance use disorders, whether it's alcohol addiction or opioids or others.
Yeah, so we just set up a small pilot study. So we measured the effects of a ketone drink, so not necessarily a ketogenic diet. That's Stephen has done repeatedly in people with Alzheimer's. So what he found is that people with Alzheimer's have insulin resistance, so low glucose utilization, but their ketone metabolism is intact. So when you give people glucose, their brain doesn't work very well in Alzheimer's and has all these cognitive effects. But if you give people ketones, suddenly their cognitive scores or their behavior went rapidly better because there's a net increase in brain energy with the ketogenic diet. Glucose goes down, but it doesn't really matter if your glucose system doesn't function that well. And ketone metabolism measured with PETs, carbon-11 acetoacetate, went up, and it correlated with behavioral and cognitive improvements. So in alcohol use disorder, we gave people a ketone drink and also saw very similar to when you give alcohol acutely, roughly a 20% reduction in glucose metabolism. But we didn't have carbon-11 acetoacetate because we didn't have that set up yet at Penn. So we used magnetic resonance spectroscopy where we could measure BHP levels. But you can only measure it in a singular box, so we couldn't really look whole brain. But I still think that the glucose metabolism, it just correlates negatively with the ketone uptake. But we did not really see group differences. So we only had 5 people with alcohol use disorder, 5 people who were regular or more sporadic or non-drinkers who came into the lab twice, once with a ketone supplement and once without anything. We saw this main effect in all 10 people of a reduction in glucose metabolism and increase in brain ketones. The AUD group also reduced their alcohol craving, but we really didn't see that the glucose metabolism went down more in the alcohol group, which is what Nora found with acetate. So that people who are heavy drinkers or have alcohol use disorder, that their brain is so used to using alcohol or acetate that delta was much larger compared to people who barely drink.
And what about, I guess it depends on what the drug that a person is addicted to is, but with some drugs, people tend to eat less, right, and have a lower body weight generally. And this kind of, at first approximation, that might be because they're craving the drug more than food, and so they go to the drug than food. But then they should have better glucose regulation based on their body weight, improved insulin sensitivity and so on. So what's the relationship, I guess, between insulin sensitivity, body weight, and addiction? I mean, that's a broad question.
That's a very hard question, but a very important one. So for all substance use disorder, we see lower dopamine D2 receptors and lower brain glucose metabolism. Cocaine use, opiate use, alcohol use. And the mechanism may be very different. So for alcohol use, there's this conversion with acetate metabolism, but that's not the case for cocaine use and opiate use or other drugs. Cannabis was slightly lower, was not as strong an effect as for the other substances. But then you're absolutely right that particularly cocaine users have lower body weight, opiate use disorder who are not on agonist treatments also have lower body weight. And I believe alcohol use disorder too, but it might, as you say, be very related to not being that interested in food because of preoccupation with the drug use. All the money goes there, and the reward of natural reinforcers such as nutrition may not be there. But then it might go to the more opposite. That's people who are that severe may just have very poor nutrition, such as people come to the hospital for alcohol detox, that they immediately need vitamin B because their nutritional status is so poor. and I've recently been more interested also in people with opioid use disorder on agonist treatment. They often increase their BMIs with like 5 points or so. So we haven't really done FTG studies there to see before and after treatment or comparison of agonist and antagonist treatment. How does that have an effect on brain glucose utilization? So I think especially with this traditional insulin resistance, I don't think there's too much known yet within substance use disorder.
Okay. And what about levels of exercise in like cocaine would intuitively I mean sometimes I guess people take cocaine so that they're more alert and maybe they're more active, whereas a different like alcohol is kind of suppresses activity. And so the obvious relationship that to energy metabolism is that exercise, you burn more calories, you tend to have better glucose regulation, so on. So have there been studies looking, of course, you got to get the person to be able to do it, but looking at the effects of exercise on craving, uh, on recovery, relapse, that kind of thing?
I'm sure there have been, but I
Okay.
don't really know. I know some studies have looked at sleep deprivation. Primarily, people with cocaine have
Hmm.
so that they only sleep maybe 4 hours or so on average compared to general population of 7 to 8, and that poor sleep was associated with dopamine D2 receptor availability. It was completely down, but it doesn't necessarily translate well. I bet if you only sleep for 4 hours, you have more more activity on the other hours. But
Yeah.
it doesn't say anything about the quality. Like you can just lay down and not do anything versus running around, of course. But yeah, I think diet and exercise have been so underlooked in substance use disorder research and mental health in general for the treatment.
Yeah. In Baltimore, they had this, I'm not sure that, I don't know the names of the people that organized this, but essentially they got drug addicts, or they weren't all drug addicts, but some are, that were homeless, and they got them into like a little running club where they'd run together each day. And they had really good results. I don't know if they published it, but I saw like an interview with the organizers and so on, and they interviewed some of the participants too.
That is fantastic. I would bet that exercise improves the dopaminergic system and also through
Yeah,
muscle gaining and losing weight, the glucose levels in the brain. And it's something that when I worked in Germany with a detox center, where people received like a month of care. They were provided very good nutrition and good exercise. And we did a 3 week study pre and post. They came to Berlin to the MRI, and people did so much healthier after 3 weeks. Of course, no more alcohol in their system, but also their diet and exercise improved so much. Whereas here, I think in the United States, the diet in hospitals is really not great. Also,
no,
even at the National Institutes of Health, people had access to all sugary things, and that's really one common thing that people who detox from one drug, it increases sugar liking and sugar intake. So that might be something really to change throughout, yeah,
yeah,
mental
it
health
seems like
practice.
there's too much emphasis on using drugs to treat everything without any like risk reduction, prevention, or like early intervention with some lifestyle modification. And the healthcare system is for profit. So I guess it would have to, I mean, there could be for profit centers, right, for that kind of thing. There are for drug addiction, right, recovery um, from drug addiction, but maybe more, but more as a
Yeah, I've worked with Care and Treatment Center here in Pennsylvania, and they have really good cafeteria food. That's right. And they do also do exercise programs.
Yeah,
But yeah, it's still hard. Like this uptake in GLP-1 agonist research
yeah,
is
yeah.
very interesting. Maybe, well, the just the injections themselves or the drug themselves make people crave alcohol less or drugs less, but also they may train people to stick to a healthier diet.
Yeah, that'll be interesting to see what happens with if there's trials. Are there trials that you're aware of with drug addiction? Because the main way that the GLP-1 peptides seems like the emerging evidence they're really good for obesity and diabetes, insulin resistance is by suppressing food intake. And particularly they seem to suppress the sugar, craving for sugar and these kind of obesogenic uh, food constituents. So then with drug addiction, with certain drugs, I don't know, is that going to make it better or
Yeah,
worse?
there have already been trials that show that in non-treatment seeking people with alcohol use disorder, so people who really don't need a detox but still drink way too much, that alcohol consumption goes down. And also Care and Treatment Center, I don't think they've published it, but they also found that people on buprenorphine with opioid use disorder that they reduced their opioid craving. But that was quite a preliminary finding. I think the sample size was pretty small. So much more is needed, but people crave also substances much less. And I know that started a study in people with alcohol use disorder on GLP-1 agonist medication during detox, and will pair this with an carbon-11 raclopride scan to look at dopaminergic effects, like dopamine D2 receptors. Do they increase again during the course of alcohol withdrawal, and also dopamine release, which is usually blunted in people with substance use disorder, which translates to not being very interested in anymore in other in natural rewards, but whether that's also affected by GLP-1.
When I was at NIA, one of the scientist in my group. He's a medicinal chemist or pharmacologist, Nigel Gregg. Actually, he's the husband of Amy Newman, who's the scientific director
Oh, great.
at NIDA. And um, Nigel and my group helped quite a bit on a lot of the studies. We're looking at direct effects of GLP-1 and one of the analogs, Exendin-4, on neurons first in culture, then in vivo. And turns out most neurons throughout the brain express receptors for GLP-1, and the receptors are coupled to a signaling pathway that's well known to be important for learning and memory, cyclic AMP
Hmm. And
pathway.
have you also shown, sorry, that the GLP-1 that they cross the blood-brain barrier? Because they should be too large, but maybe when you just
Well, they definitely get to the hypothalamus for sure,
right,
and I don't know if there's been studies like labeling and looking all through the brain. But there are receptors throughout, so kind of intuitively, why would there be receptors if there's no
exactly.
ligand or unless there's another ligand other than GLP-1, which there could be, I guess. But
Yeah,
anyway,
more because these peptides are so large, they shouldn't cross.
well, they're like 30 amino acids, 30, it's fairly large, but there are peptides that get in the brain that are that big. So, um,
It would be a great pet
and
experiment for
for
humans.
all we know, there may even be transporters for GLP-1. Um, right. So we found that um, GLP-1, if you just take cultured neurons and add it, it will increase BDNF production, brain-derived neurotrophic factor. And BDNF, as you know, it's important for almost anything the brain does, but it's very important for learning and memory and mood. And generally, it's thought and the evidence suggests that most of the drugs and other interventions that are good treatments for depression and anxiety disorders, they increase BDNF levels, and that the animal study suggests the increase in BDNF is part of the antidepressant, anti-anxiety effects.
Huh.
Um, so I'm wondering what's going on with BDNF in the brain and addiction. So, for example, I might imagine that cocaine or stimulants would you would think they would increase BDNF because it's activity dependent, and it may in the circuits may be involved in the um, addiction particularly. But do you know about that?
So I think BDNF would be chronically down. I mean, most
Yeah,
substances are so neurotoxic that it has all these profound effects,
yeah,
not only on dopamine or opioids and
yeah,
the GABAergic receptors, but also on reduce well, glucose metabolism, of course, but also just in general volume. So if you
yeah.
look at a person who has been drinking for years, gray matter volume is completely down. So I would definitely predict that BDNF is down. I'm not sure if we can measure this in humans in vivo. I do not think there's a BDNF
No.
tracer, or you do not measure this
It's in
spectroscopy.
CSF, in the cerebral
Yeah.
spinal fluid.
Okay. Oh,
Ah,
I would
there's another
bet there
thing.
are
Uh,
CSF studies that show reduced BDNF. But I'm actually interested when you said about the GLP-1 that this increases the BDNF. Was that mediated by weight loss, or was that a direct effect of GLP-1 agonists themselves?
the direct effect.
Direct effect. Wow.
We could show it in
Okay.
cultured neurons, or they're
I
just
see. I see.
neurons.
I see. So there is
Yeah,
no weight loss in the
right.
culture. Yeah.
And then in the animals where we can euthanize them and take out their brains and look, then we can look at BDNF by there's a lysis enzyme linked immunosorbent assay to quantify BDNF. You could even do immunoblots, Western blots. So
That's
there, and you can look at the messenger RNA too.
Yeah, I think the GLP-1 agonist research is going to be booming, and well,
Oh yeah,
it already is. But even in human participants using PET, we could look at glucose metabolism. Does it normalize glucose metabolism in people who are overweight? Does it decrease neuroinflammation in the brain and body? For example, we can look at dopaminergic imaging and mitochondrial health with spectroscopy. We can measure nicotinamides, adenine dinucleotides, this measure of mitochondrial health. So there's a lot to study.
yeah,
But I
yeah,
always thought that all of this was mediated through weight loss, but maybe yeah, as you say, there's direct effects. And
yeah,
it corresponds with what people say, like within the first day, people say, huh, my craving for food is
yeah,
gone. I'm not sure if it's substance use that's the same. That's with there's an immediate effect of wow, I do not want to drink alcohol anymore, or if that's more like a learned response that once you drink, alcohol may not be absorbed as rapidly, so that fun rush of alcohol in your system may not be there, and that leads to not wanting alcohol. But maybe all of this is involved. So, in direct effect, like, okay, I don't really want this dopaminergic response anymore. And also, when I drink, I don't feel as good as I used to.
yeah. Um, so so getting back to BDNF. So, um, as you know, there are well, back in the 50s, I guess, there was some evidence that psychedelics can be beneficial. I think that was for alcohol use disorder, the early work. And then there's a lot more going on in that area now that there's funding and it's essentially legal to do the experiments. And the psychedelics they profoundly increase BDNF levels too. And I don't know if you know, uh, is it Rob Malenka?
Oh yeah.
Yeah. So he came up with this term disruptive psychopharmacology, where, and it's mostly focused on MDMA and the psychedelics and they cause so much profound alterations in neural activity and changes in connect, kind of dissociating the sensory input from ongoing thoughts in your brain. So it's kind of your brain starts generating a lot of interesting experiences. And yeah, but so BDNF goes up with that too. Um,
Huh. So it might just be that
there's been,
psychedelics and alcohol just acutely increase BDNF, but then maybe at least for alcohol chronically there's a reduction with neurotoxicity.
I don't know if alcohol will increase it acutely. I might predict not. Um, so before we went on, we briefly talked about, or you mentioned intermittent fasting, which is something my lab worked on a lot. And so I wrote a paper for Nature Metabolism recently on this idea of intermittent metabolic cycling and kind of optimizing brain health and resilience, and with like exercise is obvious example where you have like a kind of, it can be moderate, even extreme, relatively short-term stress. It's a stress when you exercise. And there's big changes in your energy and metabolism, and things go on in your cells during the challenge, during the stress of exercise or fasting that set in motion, sets up the cells for the recovery period. So like during the challenge period, cells go into stress resistance, conserve resources mode. Then during the recovery period, eating, sleeping, resting, the cells, including neurons, go into a growth and plasticity mode. And so the cycling back and forth over time may optimize health. Um, so I think, yeah, I'd encourage you to try to do the intermittent fasting study if you can.
Yes,
Um,
because we primarily worked on ketones because of the shift from
yeah.
alcohol to acetates. We gave people during alcohol detoxification, we gave them a ketogenic diet, and we made sure it was blinded, so people received for 3 weeks a liquid diet that was either ketogenic or control, like 50% carb. And the people also ate some snacks on the side because in the beginning they were complaining like we need some solid food. So okay, fair enough. But especially for 3 weeks. But the effects are pretty drastic. So people are treated with benzodiazepine, GABAergic medication during alcohol withdrawal. And for some people, this is really necessary to prevent seizures, for example, especially in those first few days of very severe alcohol withdrawal. And people reported fewer alcohol withdrawal symptoms, and also a psychiatrist who provided these benzodiazepine medications based on uh, patients' withdrawal symptoms. The need for benzodiazepines was lower in the ketogenic diet group compared to the control standard American group. Um, we did not measure BDNF. I wonder if we can still look at blood levels. Never assessed CSF, but only
Yeah,
serum blood.
CSF would be ideal. It's not really clear that there's a direct relationship between blood and brain. BDNF is produced by some other organs. For example, the heart cells produce BDNF.
Huh.
And
And the liver, does the liver produce BDNF?
I don't think so.
Okay.
But yeah. And do you know about extracellular vesicles, exosomes? So all cells release these tiny vesicles. They're like 100 nanometers in diameter, and they're in the blood, circulating around in the blood. And Dimitros Papagiannis, who was a neurologist in my group, he he's developed and refined methods for isolating from the total pool of these small vesicles in plasma, in blood, a subpopulation of vesicles that are coming from neurons. So essentially the method is you have an antibody against a neuron-specific protein. And so you can use that antibody to pull those vesicles out. And then he's focused a lot of brain aging and Alzheimer's disease, so he's done a lot of nice work relevant to that. But the point is, they get these vesicles that you can isolate from plasma give you a window. It's kind of a liquid biopsy of the brain. He's shown, for example, there's insulin receptors in these vesicles, and in people with diabetes and people with early Alzheimer's disease, there's impaired insulin receptor signaling evidence for that in these vesicles. So he kind of demonstrated brain insulin resistance by looking at these vesicles.
That
So
is so
he likes
interesting.
to he likes to collaborate. So you may, because if you have samples, and you can do this on frozen samples of blood or plasma, you
Yeah,
know.
we
Yeah.
still have frozen sample of plasma and serum for these patients. So for 3 weeks, we took a plasma sample every week. So
Yeah.
for people on a keto diet versus a control diet, yeah, that'd be great. We did MRI imaging and showed also decreased more, well, not dopaminergic responses, more cue activities. So the nucleus accumbens, prefrontal cortex, those responses were reduced in people on a ketogenic diet when they looked at alcohol cues compared to food and neutral cues. And then with spectroscopy, we saw some evidence of reduced inflammatory markers. But surprisingly, glutamate levels went up. I would have totally predicted them to be down. If during withdrawal you get into this hyper excitable state with high glutamate, and then with the ketogenic diet, if anything, I would have predicted lower glutamate. And we wanted
But
to measure GABA.
the problem with that, Corinne, is that it's measuring the whole tissue
Yes.
glutamate, and what's important is how much is at the synapse and how much is being released, because most of the glutamate is inside the cells. There's very little glutamate extracellularly, so I don't know. Maybe that's like it could be a compensatory response to reduced release of glutamate or something like that.
Yeah, and also we weren't able to measure GABA, so it might have also been like, if glutamate is increased, that may have converted to more GABA or
Yeah.
something like that. But yeah, you look at a 1 by 1 centimeter voxel in the anterior cingulate cortex, and there's obviously so much going on within that voxel that we cannot see with spectroscopy.
So you have evidence that the ketones are beneficial in the patients with alcohol use disorder. What about other uh, substance abuse disorders, substance use disorders?
So I haven't worked on this directly, but there are some animal studies that show that it also reduces cocaine intake with cocaine use disorder. And my colleague Pete Menza, he's now an assistant professor at University of Maryland in Baltimore. He's
Hmm.
going to test ketone supplementation during opioid withdrawal.
Okay.
So the ketone drinks, when I moved to Penn, I thought, oh, 3 week ketogenic diet study is so hard.
Yeah.
It's so hard to police people sticking to the diet. And if that's already so hard, do people really stick to it in everyday life? So why not treat people with an alcohol addiction with a drink that immediately shifts their brain energetics and might decrease alcohol craving? So I've shifted a little bit more to Richard Veitch's ketone ester and then the kinetic ketone supplement. And we just did a trial in alcohol withdrawal at Care and Treatment Center, and we surprisingly didn't really see an effect on benzodiazepine use or alcohol withdrawal, but it may have been because all patients were tapered on benzos immediately when they came in. So
Hmm.
everybody received a similar dose, and it was very high. So benzo or the benzodiazepines were fixed. So even we could have given them as much ketones as we wanted, and even if it helped, we would not have seen
Yeah.
it
Yeah. Yeah.
because the withdrawal symptoms were pretty low with that high benzo taper. So we're repeating this study now here at the hospital at Penn. and also add an MRI scan at the end to look at mitochondrial health and resting state, functional connectivity, and all these kind of measures. And we will measure GABA. That will be very interesting to see. It's like, okay, if people drink these ketone supplements, might this elevate GABA and therefore reduce the need for benzodiazepine medication. But we've done a few studies more in like an alcohol bar lab setting where people who were regular drinkers, we gave them these ketone drinks before roughly 3 shots of vodka, and they did not like the effect of vodka anymore. So and also the breath alcohol levels were very low. So it seemed that these ketone drinks prevented alcohol from being absorbed. So then what's the point of drinking if you don't have that nice rush? Uh,
Interesting.
so we're now bringing that to an alcohol dependent sample. If NIH currently will release grants, and I've been waiting for my R1 for 7 months now, and it's still not there. My goodness.
Uh,
But yeah, hopefully we'll see something very similar. That's if people with an alcohol use disorder we're not treatment seeking, otherwise we can't give them alcohol in a bar lab setting. If we give them these ketone drinks before, and then alcohol, and then we give them ad libitum alcohol, does it also reduce alcohol consumption in a lab setting? And my prediction is absolutely. If you don't crave alcohol because of this shift in brain energetics, and alcohol doesn't get absorbed, then this should lead to a reduction in drinking. But it's the mechanisms are very different from a ketogenic diet because we did a parallel animal study with Leandrov and Ruscolo, who you probably know very well at NIDA in Baltimore. So he ran an experiment where rats who were alcohol dependent were on a ketogenic diet versus control diets, and then gave them alcohol. They have this vapor chamber where rats are vaping alcohol for 14 hours a day. But the poor rats on a ketogenic diet, they couldn't tolerate alcohol at all. So their blood levels of alcohol were 5 times higher. So, well, they couldn't self-administer alcohol after those 14-hour vapes. Um,
so
and also,
it's inhibiting the metabolism of alcohol?
yeah, so we followed up on that and took out the livers, and it looks like the alcohol dehydrogenase is downregulated. So we haven't
Hmm.
translated this to humans yet, or well, we have. We started the experiments, but we did only a 3-day ketogenic diet in humans. It doesn't really have an effect on alcohol
But it
metabolism.
could, so ketogenic diet, uh, elevation of ketones is not the only thing that happens because these ketogenic diets are very high in saturated fat. Essentially, that's what it's like eating butter or lard or something
Yeah,
like that. So um, I guess what I'm saying is that I think that doesn't necessarily mean that the ketone themselves will have the same effect as
yeah,
a ketogenic diet.
absolutely. So there are all these I really came from this whole metabolic shift from glucose to acetate, but there's so many more systems in place. So if it's just that metabolic shift, it shouldn't matter, right? Elevation of ketones through intermittent fasting or a ketogenic diet or these exogenous ketone drinks. But you see all these other effects on even alcohol absorption that may contradict or even have differential effects then on the consumption. So.
The the ketones, yeah, so they have signaling functions. It's very clear now. Essentially, I consider ketones, particularly beta hydroxybutyrate, BHB, the BHB ester you're using. Um, I think it's a hormone. It's released from liver in response to fasting or extended exercise, and it circulates in the blood to various organ systems, including the brain. And yeah, it's used to produce ATP, but there's multiple different pathways that there's evidence in the literature it uses to affect gene expression in cells. And we found BHB will stimulate the BDNF gene and increase BDNF mRNA and protein levels. You mentioned GABA, and as you alluded to, but I don't think you mentioned it. So ketogenic diets and BHB will suppress seizures. And ketogenic diets are used in the clinic for people who don't respond to epilepsy drugs well, but BHB will do the same thing. We've shown that. And then we've shown in animals by recording, we put an electrode in a glutamatergic neuron in the hippocampus, which is a brain region we focused on a lot because its role in learning and memory and also in mood regulation. And then we recorded something called inhibitory postsynaptic potential. So it's essentially GABA being released from an inhibitory neuron onto the excitatory neuron. And we found that the intermittent fasting enhanced the GABAergic tone
Mhm.
and and protected against seizures. Actually, the first paper we published on intermittent fasting in the 1990s, we showed that it protected against seizures induced by a excitatory amino acid called canic acid.
Wow.
Um,
So is then an increase in this IPSP, does it correspond to an enhanced GABAergic tone?
yeah, yeah,
Okay.
yep.
And fasting did that? Did BHP do this directly too?
Um, we didn't do the recording, but what we did look at is seizures. We recorded electroencephalogram, EEG, and so we could look at, if you have a really severe seizure, you can see the animal freezing or clenching its teeth and so on, or shaking. Um, but you can have like subclinical seizures essentially, or increased bursts of activity. And yeah, so we gave the ketone ester to mice and it suppressed the seizures.
And do you know clinically, because for example, in Baltimore at Hopkins, there's a clinic that
Yeah, yeah.
specializes in a ketogenic diet for seizures. But would intermittent fasting, would that lead to similar effects?
Yes, I've tried to get them to do the trial of
But they
people.
haven't done it yet.
They haven't done it yet,
Yeah, I
but
guess the trouble with the intermittent fasting and with the ketone drinks is that you have more variability in BHB levels. If BHB is really the contributor, then you would
yeah,
like
that's true.
maintain a stable and the only the
But
only way to do that is
well,
being in steady
interestingly,
ketosis.
the intermittent fasting, we found that it takes at least 2 weeks for us to be able to see the increased GABAergic tone.
Okay.
So it's not an acute effect. It required, several rounds of uh, fasting, eating, fasting, eating, fasting, eating. So intermittent ketogenic state. Um, yeah, so
So that might also be too long for somebody in acute alcohol detox for those first 5 days. Even
yes.
a ketogenic diet was because we had an ethical problem. So ideally, when somebody comes to the hospital, well, ideally the experiment was we give people a ketogenic diet when they're still drinking. Then 2 days later, when they're in ketosis, they come to the hospital and then they detox of alcohol. So their levels of ketosis was stable. But ethically, we can do that because you can't bring somebody to the hospital, give them a ketogenic
Yeah.
diet, send them back home to drink, and then come back later in 2 days. They needed to be admitted, they were patients, and they needed help. So
Yeah.
it still took 1 to 2 days to get into ketosis. And that's exactly that breakpoint where we saw the effect on the need for benzodiazepines, that it was reduced once people were in ketosis. So that's, yeah, the ketone supplements, the ketone esters should overcome that problem. And there have been some animal studies that show that the ketone ester was similarly efficacious in reducing alcohol withdrawal in rodents compared to the diet.
Right. So there's some problems with the substance use disorders that, like the one you are issues, ethical issues. And what about an addiction that doesn't involve drugs, like gambling? Gambling's a big deal is sports gambling now. There's a lot of people getting addicted to sports gambling. There's ads all over the place. Particularly people who like sports, follow sports, right? These online gambling companies will say, will essentially say, we'll give you $200, um, that you can use to see how the gambling goes. And then some of them, the idea is, it's kind of cruel in a way, but the company's idea is that some of these people will become addicted, or not necessarily addicted even to where it drastically affects their life, but enough to keep spending more than $200. And of course, in the long run, with gambling, in the long run, you're going to lose money.
Yeah,
It's all rigged
and they
in
still
that
deliver
way.
tradition.
But it might be, someone with a gambling addiction might be interesting to try in them. I don't know if is there people up at Penn that are studying gambling addiction?
No, not at the Center for Studies of Addiction. Nobody's studying gambling, surprisingly. And we've just started first cannabis use disorder. Also, traditionally, people don't study it. It's opiate use disorder, alcohol use
Yeah,
disorder, cocaine use disorder, and some methamphetamine. So gambling we haven't started, but it's could be almost more like a pure addiction, right? Without the interference of
right.
substances themselves. But I would predict that, yeah, being in ketosis would reduce the need for this dopaminergic stimulation constantly, and I bet GLP-1 agonist medication would have a similar effect. So for ketones, it also reduces appetite, for example, and the craving for
Yeah, yeah, yeah,
sugar-rich food, which I totally think is an addiction too,
yeah.
particularly if you don't have this increase in glucose spikes throughout the day that's only want you to eat more.
Yeah, so that might be interesting to see who's doing stuff with gambling addiction, and if it's
I
a
know
whole
that
nother
in China
gram.
it's such
I
a
mean,
big field.
right. I mean, you've got the whole setup there, Penn. You just have to go to your grant proposal and replace alcohol use disorder with gambling use disorder, and
Yes.
then submit the proposal.
If anything gets funded these days, it's a really hard time because with the proposals
Oh
of
yeah,
30% reduction of the NIH money, my goodness, like how will we all
and it
survive?
keeps. I mean, it's so sporadic. A few weeks ago, it looked like they're gonna, you know, kind of reinstate funding for a lot of people. Then I saw something just a few days ago that the Supreme Court says they don't have to, um, essentially don't have to, even though this was congressionally uh,
Money put,
authorized,
yeah,
the money that, so I don't know. It's crazy time.
definitely a crazy time. We'll stick around, but I'm lucky to have a European passport. I could always go to Europe, and they're trying to attract people from the United States. But
I know. I know.
honestly, I mean, there's nothing like the NIH for research funding.
Yeah.
When I compare what I've been able to do in the last 10 years here in the United States compared to Europe, there's no way it could have.
Go to Denmark and do GLP-1 addiction stuff.
That
Right,
would be
because
great.
they have, is it Novo Nordisk is there?
Yeah, Novo Nordisk is
That's like,
currently the main producer of well, money basically in or the economy in Denmark. And yeah, Anders Fink Jensen, he's a professor and a psychiatrist in Copenhagen. He really put GLP-1 medications on the
yeah.
market or in the field of alcohol use disorder. So he did the animal studies also with the
Ah,
ketone monoester and a ketogenic diet in animals. But he already said 5 years ago, I was like, Corinde, why are you are so interested in these ketones? Look at the results of GLP-1 agonists. It's like, yeah, but nobody wants to do that with injections. Like, why would you want to take an injection every week? And look at the field now. So many people benefit from these drugs.
yeah, that's still surprising to me because it's like a hormone, and usually hormones, they're released in response to some signal. So GLP-1's released from the gut into the blood when you eat, particularly sugars. And then it goes to the brain, and it also affects insulin production in pancreas and insulin sensitivity of liver and muscle. And so it's normally GLP-1's only produced transiently, and it's actually down most of the time,
Hmm.
right? So now you have the subcutaneous GLP-1, so constant release. So you got constantly elevated GLP-1, and it's just surprising to me that that doesn't have some more adverse side effects than have shown up so
What
far.
side effects would you predict?
I don't know,
I mean,
but
there's an increase in pancreatitis, some people, but it's very
yeah.
rare. And then the increase in, or some people claim that it's induced blindness. Uh, what else?
Well, I think we don't know, right?
Psychiatric.
Because we know a couple things it does. Well, anorexia is one thing.
Yeah.
So if you start, if you have someone with, say, opioid use disorder who's already low body weight or cocaine or whatever, and then you give GLP-1 and now they have, they previously had 20% of their normal appetite, now they have like zero, that's not going to be good long term. I guess if it gets them off the addiction, yeah, I don't know. It's hard to say what's going to happen. Yeah.
Yeah. But there might also be like this loss of control and dopaminergic craving for substances may be very tightly correlated with craving for food. So there may also be very different people who have anorexia and
Oh,
an opioid substance use disorder.
I see.
Maybe more taking it to suppress negative feelings, for example. Yeah.
Yeah.
So we
Oh,
really should go look more at yeah, personalized medicine. But I completely agree with you that GLP-1 medication could be dangerous for people who are already low body weight.
yeah.
Why suppress appetite more? And it should be seen as almost more like a serious side effect than for using it off-label for
Yeah. Yeah.
addiction.
You're better off with exercise or moderation in calorie intake, intermittent fasting.
Yeah, but
Um,
the interesting thing is that so many people show now, like, oh, I've done exercise for 10 years, but with the GLP-1, finally I don't have this food noise. And this is the only way now I can reduce weight. Like
uh,
exercise alone may not necessarily reduce weight in many people because they just keep eating. But yeah, tracking or eating more after
yeah.
they come home from the gym. And
Yeah.
but intermittent fasting, yeah.
Well, that's because they're sitting at the front of the screen doing sports gambling and eating junk food.
Yeah, it's hard.
What?
Well, it's also hard in America. It's just food is available everywhere. Like when we European or international postdocs came to the NIH, we all gained weight in their first year, and we
Yeah.
didn't know why. It's like we're
Oh,
doing
it's the
the
same.
same.
This is, and then now we've exported this to Asia. It used to be that like in the 90s, even early 2000s, I'd have say a postdoc from Japan or South Korea or China, and they uniformly have like, I'd say low, low normal body weight.
Yeah,
And then when they, they do a postdoc for 4 years or whatever, 5 years sometimes, and then yeah, they gain weight. But then now there's Kentucky Fried Chicken and McDonald's and high fructose corn syrup in drinks in those. I don't know about China, maybe not in China, but definitely in Japan, definitely in South Korea. So first it was tobacco where we had big problem here with nicotine addiction, tobacco. Well, it still is, but it's not as big as it used to. And then finally the tobacco companies had to do something and there's some improvements, but then they just started selling all their tobacco to Asia, the American uh, uh, tobacco. industry. So now there's a lot more people smoking in Asia than there used to be.
Yeah, I know. It's one of the first thing in coming to the United States, like why are people so big and nobody smokes?
Yeah.
Why is alcohol so expensive? Some people don't drink as much. But yeah,
Okay.
long-term effects of GLP-1 also just it might also there are some incidents also that people say like, yes, I lost a lot of weight, but now um there are also anxiety and depression seem to go a little bit higher. It might also just be like the the amount of pleasure you get from eating wonderful food may also be eliminated to some degree. So that may also influence in the long term. Like, yeah,
It could
but
be. To finish up, what about aging? Typically, I guess me included, think of people with a substance use disorder are often younger or middle age and what about addiction and aging? Is there much research at all done on that?
um, well, particularly alcohol, I mean, there's definitely high use of alcohol in the elderly, and
Yeah,
that becomes a more increasing problem. So yeah, the most drinking occurs
yeah.
in younger adults, maybe adolescents, younger adults, college, and then when people get more responsibilities, having a job, having a family, it just decreases again, and people don't really have a substance use disorder for life. But then there's a more recent uptick in the aging population of drinking. Um, but in terms of the research, like I think aging and substance use have very parallel brain processes, reduced gray matter volume, white matter volume, the glucose metabolism, very parallel in terms of it reduces with age, reduces with substance use disorder. Mitochondrial health is both declined. Resting state brain functional connectivity declines with aging, declines with substance use disorder. So there's a more interest in looking at substance use disorder as a model of accelerated aging, and
Ah,
also
yeah, yeah.
evidence, of course, that substance use disorder may lead to dementia and Alzheimer's disease, more aging related diseases. Um, but yeah, I'm not sure if that
And then inflammation too, right?
and inflammation, absolutely,
Yeah.
absolutely, yeah.
So then it kind of makes sense uh, that lifestyle factors that kind of counteract aging might also at least counteract, if not being, extremely effective in reducing addiction, may help lessen the adverse consequences, in people who recover. Because you can imagine if you have addiction for some extended time period, during that time period, there's a lot of bad things going on. And then even if you recover, having gone through that period may lead to earlier onset of age-related problems.
Yeah. But then there's always this, I mean, one used to think like, oh, well, maybe one glass of alcohol per day might be good for the heart and good for your mood, etc. But now the evidence really shows like, no, there's no safe alcohol. It leads to all these different cancers. But still, if you look at the statistic in terms of people who are completely abstinent versus people who may drink occasionally, the people who drink occasionally still live longer lives, but it might be somewhat flawed, namely that people who don't drink at all, that they don't drink because of other health conditions. But even in animals, the animals who prefer alcohol tend to live longer, I believe, but I don't know exactly. I need to look at the original papers. That animals who prefer alcohol actually live longer than animals who don't prefer alcohol. So there might be some evolutionary benefits to liking alcohol. Maybe
It
it's
may
just
have to do with the taste. So, the reason some people, particularly children, don't like to eat vegetables and certain fruits is because they have very bitter taste. And I remember like the first time I drank some beer, it had a very bitter taste. It's something like the first time you drink it, you'd say, "Oh, that's really bitter. I don't like," or even coffee. And so there's but these bitter tasting chemicals are, I guess what I'm pointing out, maybe, the bitter taste will,
Will prevent you.
yeah, I don't know.
Yeah, I
Yeah.
think Bacardi Breezer has solved that problem by just selling all these colorful, sweet drink
Oh, yeah,
alcohol
yeah, yeah.
that hooks younger um,
Oh,
children, adolescents up to drinking alcohol.
it could be a
And it's
double whammy.
but it's the same with alcohol or rats making them drink alcohol. You first have to increase sugar content, and then they'll drink. Then they learn to parody taste with the
Ah,
effect, and they'll drink it even without sugar. And I
ah.
think it's the same for
Well, that
humans.
makes sense, right? Wine has sugar in it. Beer has carbohydrates, so unless you're drinking like pure alcohol, uh, the- I guess what I'm saying is people will more easily consume those things that
Yeah,
have something sweet.
yeah.
Yeah.
Yeah, and there's some research that suggests that people who are super tasters, so they just taste the intensity of bitter much more intense, that they're more protected against or that they reduce or it reduces their drinking of alcohol and coffee because
Interesting.
they just can't get over the taste. So
Interesting.
even if they like the effect of alcohol, they wouldn't still drink it.
Hmm.
So.
Interesting. Okay, well, we've used up a little more than an hour now. I enjoyed talking with you, Corinne, and keep up the good work. I hope the NIH gets your money to you soon. I take it you got a good score.
Yeah, the score was 23. It was an ESI, it was RO1, so it should have
Yeah.
been funded in December. But yeah, then especially earlier this year, I mean, December usually becomes February, and then Trump came into office, and I think yeah, many grants, of course, got defunded, and there's all these regulations with the indirect costs and many court orders. So it's just been
Yeah.
a longer journey, but
Yeah.
I'm still hopeful that it will come one day.
Okay. Well, nice to meet you. Thanks for taking the time.
Thank you so much for having me.
Bye.